Hello, my name is Katarzyna and I'm a graduate student in the Masters of Health Informatics program at George Mason University. Today I'll be presenting a performance analysis of MedStar Georgetown University Hospital, focusing on 5 infection and sepsis related quality indicators compared to its local DC area competitors. All data comes from the CMS Hospital Compare Dataset, a publicly available federal database maintained by Centers for Medicare and Medicaid Services. I pulled data spanning 2020 through 2025, giving us a 5-year longitudinal view that includes the COVID-19 pandemic period, which is an important backdrop for any infection-related metrics. Before diving in, one important caveat: CMS data carries approximately a 5% error rate stemming from reporting inconsistencies across hospitals, differences in patient populations, and varying documentation practices. So while the trends I'll show are meaningful, they should be interpreted with that margin of uncertainty in mind. Georgetown's 4 direct competitors are all Washington, D.C. area hospitals serving the same geographic region. These include George Washington University Hospital, Howard University Hospital, Sibley Memorial Hospital, and MedStar Washington Hospital Center. These are true peers, urban, academic, or community hospitals competing for the same patients in the same market. So this is our first indicator, which is the overall hospital rating. It is a patient satisfaction score derived from patient surveys. Georgetown remained within control limits for the entire study period, staying between the upper control limit of about 87 and a lower control limit of around 79. So this is a positive finding. That being said, there was a notable downward trend worth flagging. Georgetown scored roughly 89 in 2020, which is great, but then declined to between 85 and 86 by 2023 and 2024. This drift does warrant attention. Declining satisfaction scores often reflect inconsistencies in how care teams communicate with patients, and catching this trend early gives leadership an opportunity to course correct before it becomes a bigger problem. And I think it is no surprise that there was a downward trend after the year 2020, which was the pandemic. The second indicator is CLABSI, central line associated bloodstream infections, measured using the standardized infection ratio, where lower is better and 1.0 represents the national benchmark. Georgetown was within the control limits aside from 2023, which is a good thing. There were a couple of spikes in 2022 and 2025, however, it stayed within the limits. Central line prevention is highly dependent on reliable bundle compliance and daily necessity reviews, and this fatality points to an opportunity for more durable process improvements. The third indicator is CAUT, catheter-associated urinary tract infections, also measured by the SIR. Performance is good. Scores trended downward from about 0.622 to around 0.2 by 2023 and 2025. Well below the national benchmark of about 1.0. In 2023, the score dipped just below the lower control limit of 0.2, which technically flags outside limits, but it's important to know that this is a good direction. Fewer infections than statistically expected is a sign that catheter management protocols are working well. The score recovered back within limits by 2024, so overall good performance. The fourth indicator is C. diff, a bacterial infection closely tied to antibiotic stewardship and infection control practices. Georgetown performed within control limits across the entire study period, with SIR scores between 0.55 and 0.65. This consistency is encouraging. It shows that Georgetown's antibiotic stewardship program is functioning well, with clinical and pharmacy teams making appropriately selective decisions about antibiotic prescribing throughout the 5-year period. And our last performance indicator is the sepsis bundle, which measures appropriate and timely care for severe sepsis and septic shock. Unlike the infection ratios, SEP1 is a process compliance measure scored as a percentage of eligible patients who received the full sepsis bundle. Georgetown remained within control limits throughout the study period, with scores fluctuating 38 to 51. While staying within limits is positive, I note that Georgetown's absolute scores are in the lower half of the range. There is meaningful room to improve bundle completion rates. Sepsis is the leading cause of hospital mortality in the U.S., so even within limits, performance here represents an opportunity. Overall, Georgetown's performance exceeds that of its competitors. There was 2 indicators within limits and 3 outside. However, these were all positive findings for Georgetown University. However, there's always opportunity to improve and to look at the numbers within each indicator and see where that room for improvement lies.